Thanks, Minerva. Okay, good morning and welcome to the WellMed Charitable Foundation's Caregiver Teleconnection series for professionals this month. And today we have one on diversity and caregiving. And we are lucky enough to have our experts who have given us so much information in the past, and I'm sure will in the future too. Dr. Elliot Sklar is a public health professional with 2 decades of experience in supporting the health of the public through academic work, research, and in service. He has led healthy aging programs for seniors and for caregivers in Canada, Florida, and virtually. And his research is focused on the complexity of issues related to aging and caregiving. Dr. Sklar is an associate professor of healthcare sciences at Nova Southeastern University in Florida. He publishes and presents his work internationally. He recently published research in the American Journal of Occupational Therapy, the Journal of Applied Gerontology, and the Journal of Social Services Research. Lucy Barylak has a master's degree in social work from McGill University. She is presently working as a consultant for a health network in Montreal, Canada. She has been involved in various research projects and has published numerous articles related to caregiving issues. She has lectured at several universities and colleges on innovative approaches to caregiving and presents annually at international and national conferences. Lucy is also a consultant for private industry in the United States, including the WellMed Charitable Foundation and their clinics in Texas. And in addition, Lucy would like you to know that she was a caregiver for her mom for 10 years. With that, Lucy, Elliot, please take it away.
Thank you so much, and thanks to all our participants for joining us. We have a great program today, and I'm going to briefly go over our learning objectives, which will include talking about the role of diversity in healthcare, demonstrating basic knowledge of cultural competence, it's a big buzz term, recognize differences in caregiver experience based upon gender and sexuality, identify strategies for supporting diverse patients and caregivers, and finally, to distinguish opportunities for achieving cultural competence in long-term care. Now, I wanted to ask everyone and start out by asking what culture means to you, because we need to make sure that everyone has a same understanding of culture in order for us to have this conversation. So I would love to get your input. You can enter any comments in the chat box, and you can also unmute
or press star six. There you go.
Any takers? Lucy, Evelyn, what does culture mean to you?
Well, culture means to me, it has to do with language. It has to do with how we are raised. It has to do with our backgrounds, our values, even has to do with food.
Yeah.
Absolutely.
And religion and disability, and if we're a man or a woman, because we were raised differently, different expectations. I mean, there's so many things. That list could go on and on and on.
Well, absolutely true. And culture really is the sum of symbols and language, norms, values, artifacts, all the things that you were talking about. Language also makes effective social interaction possible, and it influences how people conceive of different concepts and objects. And as you mentioned, of course, culture is certainly influenced by our upbringing. And I included here my favorite quote, which is that we don't see things as they are, we see them as we are, because I believe that to be so very true. But I was also thinking that culture extends beyond just ourselves. Culture is true for different parts of cities. If you think about where it is that you live, the culture in one part of the city or one neighborhood might be very different than the culture in another. The other thing that is also very true is that healthcare environments have their own culture. Prior to living in Fort Lauderdale, where I live now, my closest hospital is called Holy Cross, and the environment there is certainly one of a religious healthcare environment. And previous to that, when I lived on Miami Beach, all of my doctors were at Mount Sinai Hospital, which is more Jewish and very, very different. So there's a long history of culture and religion being connected to the delivery of healthcare too, which is important for our discussion today. But caregivers are very diverse. I wish that we had new data, but since the pandemic, no new data has come out. So the numbers that you're seeing here are reflective of the Caregiving in the United States report from 2020, which is the newest data that we have, and it's published by the AARP and National Alliance for Caregiving. But about 40% of caregivers are culturally diverse, and I've included the breakdown there. But in addition to that, what I think is very important too is that there is about 11% of caregivers identified being enrolled in college, in addition to serving as being a caregiver. About 9% reported serving in the armed forces, and about 8% self-identified as part of the LGBTQ plus community. Now, I think it's important to note that we know that there's a lot of underreporting here. Many people, especially from diverse backgrounds, see caregiving as part of the role of growing older in a family. And younger people take care of their loved ones. It's part of the culture. So they are less likely to self-identify as being caregivers. And that can be a challenge. I think the other thing that's important too is that the data is averaged across the US. And as we know, certain pockets of areas have higher concentrations of diversity. And as such, there would be higher concentrations of diversity among caregivers. Now, the other thing is that we need to think about generations and the life course, things that are tied to culture, Evelyn and Lucy, that you mentioned as well. You know, if you think about the average age of a care recipient, that varies by race and ethnicity. White caregivers actually care for the oldest care recipients, about 70.5 years of age on average. This is much older than African-American caregivers and Hispanic caregivers. African-American caregivers typically care for someone about 64.9 years of age, and Hispanic caregivers about 66.9 years of age. So it's really representative of health inequities that exist in our society. For example, the life expectancy in the US of white people is older than it is for African Americans. And the differences in life expectancy are greater the older a person is. So for example, if you were born in 1950, there's a greater difference in life expectancy by race and ethnicity than if you were born in the year 2000. Now, despite these reported percentages, as I was mentioning, we know that there's underreporting. Lucy and I do a lot of work with the LGBTQ community, and in that community, caregivers are roughly about 1 in 5 adults, whereas their non-LGBTQ counterparts, the caregiving rate is roughly 1 in 6. So, you know, this is all just to say that I think as we're becoming a more diverse society, there are more diverse caregivers, and that would simply make sense. But that's not always reflected. And what I have here is a screenshot of images when I use the term family caregiver in a Google search. And I often do this exercise when I put slides together to get images. But it's very, very unfortunate that what you see here is that most caregivers are depicted as women. Most healthcare workers supporting seniors and caregivers are depicted as women of color. Now, the common depictions of caregivers and outreach efforts to the caregiving population has really not caught up to the reality of caregiving in America. And when it comes to medical care, studies have found that African American and Hispanic caregivers report feeling invisible in medical facilities. Caregivers know their partners or care recipients' medical history, symptoms, their needs. But when there are communication breakdowns with medical providers, that can result in poor response or dismissal of the caregiver's input. And as we know, patients are certainly bound to suffer. Before I go on, I was just curious if anyone had any thoughts or any feedback to this Google search of images for what is reflected when you look up the term family caregiver.
Okay, participants, this is your chance. We want to hear from you. Press *6 if you're on the phone, press unmute yourself if you're on Zoom, and I will recognize you from my little fancy website here.
I always just find it very interesting. I sometimes wonder if Google imitates life or if life imitates Google.
I was just going to say that, Elliot. It's very interesting because in the reality, our society in North America is becoming very diverse. And many times it's not reflected in things that and especially, I have to say, when we look at images, that's what hit me really very strongly.
Anybody else? Okay.
All right. Well, for those who do work professionally with caregivers, cultural sensitivity is very important. And I think trainings like this are helpful to reduce presumptions and misconceptions about others' experiences, but also to ensure the best results possible for caregivers and care partners. Caregivers are diverse, and we should be working with them in an inclusive manner. So some points of commonality or relation are important, and you can ask questions. For example, if you're in someone's home, is that soup that I'm smelling or what have you that you might pick up upon, or sharing something about the warm weather. Ahead of our programs, we always talk about the weather and how the weather is in different parts of the country where people are located. But it's a good point of commonality. It's also really important for healthcare workers to familiarize themselves with local resources for culturally diverse caregivers. For example, many programs exist through temples and churches, local community centers, and nonprofit organizations. And you can certainly find a lot of those by looking on Google or by calling 211. And ask your caregivers as well to educate you about their culture or tradition. This is really the best way to show an interest and do what we call an appreciative inquiry. So it makes people feel like you're taking a vested interest in their culture and their background.
Well, thank you for that. It's really important today, our session, we're looking at diversity, and I do have a question. Does gender of a caregiver matter?
Are you asking the participants?
I am asking
Okay, folks, come on. Give us some answers here.
Does gender of a caregiver matter? Do you think it does? What about your own experience?
We have a very quiet group today.
Well, it's a topic that's kind of makes you want to think a little bit, thoughts about maybe you haven't thought about, or if you have. Well, I have to say, go ahead. No, go ahead.
I can share. I was on a Zoom call with Dr. Pradario, who's one of our few geriatric psychiatrists in the United States. There are 4,000 for 35 million seniors. And he was giving us statistics about how men report 1/3 the depression, older men, than women. And I asked him, I said, well, is that because they don't report it? And he goes, aha. He says, you're right. He says, because men, they're strong, it's the way they're brought up. They're macho, and especially in the Hispanic community, where that's their role is to be the strong one. So I think it obviously, has a difference whether you're raised as a guy or as a girl, and as you grow up, what you choose.
For sure. I think we had 2 comments on the chat. I think 3 actually. Could someone kind of look at them?
Yeah. Kate said that gender can matter. Yes. Marie also says yes, gender matters. And let me just scroll up. Dorsey said, yes, of course it matters. A female may prefer a female and vice versa, but it also depends on the task.
For sure. So I'm glad to hear that, yes, gender does matter for sure. So within our complex system of long-term care, Women's caregiving is essential in providing a backbone of support. So we know that. In fact, the value of the informal care that women provide ranges from 148 billion to 188 billion annually. Women provide the majority of informal care to spouse, parents, parents-in-law, friends, partners, neighbors, and they play many roles while caregiving. As we know, there's hands-on providing, care manager, friend, companion, surrogate, decision maker, and advocate. So I just want to go through a little bit. Some of the studies have looked at the role of women and family caregiving. Although not all have addressed gender issues and caregiving specifically, the results are still focused on women because they are the majority of informal providers in this country. Caregiving poses greater financial challenges for many women workers, due mostly to lost wages from reduced work hours, time out of the workplace, family leave, or many women take early retirement. Women are more often caring for two or more adults, 27% versus 20% of men caregivers. A greater proportion of caregivers report caring for a man, 39%. Then in 2015, it was 35%. So things are rising. 41% of caregivers who have been providing care for 5 years or longer or more often report caring for a man. 43% of caregivers of baby boomers are caring for a man. So there's been an increase since 2015. Studies find that men respond to caregiving responsibilities in a fundamental different way. So let's look at that. Women tend to stay home to provide time-consuming care to one or more ill or disabled friend or family member, while men respond to loved one needs for support by delaying retirement, in part to shoulder the financial burden associated with long-term care. The impact of women's intense caregiving can be substantial. So we know that. So let's look at another study. 1 in 5 female caregivers aged 18 to 39 said the stress was nearly always present in their lives, nearly twice as many as those who were not caregivers and for male caregivers. So that's huge. The negative impact on caregivers' relationship and social networks due to their reduced ability to participate in activities outside their caregiving role can lead to caregivers experience social isolation. And we always talk about that caregivers really have to be conscious of not being isolated, which in turn can impact on their psychological well-being. Studies have demonstrated that women are more vulnerable than men to the effect of reduced social support. Okay, so we're much more social beings. The physical impact of providing care can lead to long-term care needs for female caregivers. For example, a national survey found that 21% of female caregivers had mammograms less often. So what it really means that 25% of women caregivers have health problems as a result of their caring activities because they're not taking the time to care for themselves. Coronary heart disease, CHD, is one of the physical risk factors of caregiving. Women who spend 9 or more hours a week caring for an ill or disabled spouse or a partner increases their CHD risk twofold. Other health effects include elevated blood pressure and increased risk of developing hypertension, lower perceived health status, poor immune function, slower wound healing, and an increased risk of mortality. So these are really things that we have to be very aware as healthcare workers. So frequently, support services can make a real difference in the day-to-day lives of caregivers. Research has shown, for example, that counseling and support groups in combination with the respite and other services have positive direct effects on health behavior practices and assist caregivers in remaining in their caregiving role longer, if they choose to, with less stress and greater satisfaction. In fact, women are more than twice as likely as men to say that they would benefit from talking to someone about their caregiving experience. Further, some studies have shown that actual linkage to services in lieu of information only programs are more beneficial to caregivers. That's really interesting. So the WellMed Charitable Foundation Caregiver Teleconnection, which we're on now, is a great example of this, where participants can share their experience and learn from one another and not feel that they're alone and not feel that they're the only ones who feel guilty or angry. So I'm just wondering, I mean, I said an awful lot, a lot of research has been done. Have any of you who are participating with us today, have you experienced that? Does it tell you what the research is actually saying? So let's hear your comments, or if you want to put it on a chat, please do so.
Sure. Press *6, use the chat room, or unmute yourself on Zoom, and I'll be able to see who wants to talk to us. Well, may I make a tangential sort of comment? Would that be okay?
Sure.
I have lived through a cultural shift. The millennials, the men, are so different now. They were brought up different by women who worked so that they had to share responsibilities around the house, and they expect to share responsibilities when they get married. And I see them all the time pushing their babies at the beach or at the park. And it's been a cultural shift.
Well,
Very true.
I think that's where Elliot is going to speak about men caregiving.
Oh, sorry.
No, it's just a beautiful introduction. But before we go, I just wanted to sort of just as someone who, as you said, Evelyn, I took care of my mother for over 10 years. And even though I was in the healthcare profession and knew a lot about caregiving, a lot of what I was telling you really does impact on women particularly. So we have to be very conscious of that.
Yeah, they leave promotions behind because they can't take any more stress. They get less Social Security, and so many issues for them.
Yeah, absolutely. And I think of some of the comments that our participants shared, and particularly Dorothy had said that, for example, a woman might prefer a female caregiver. And that may be true, but that isn't necessarily always going to be the option. And that's, I think, why it's so important that we share these specific tips that have been found helpful, generally speaking, in research for supporting female caregivers. So I think the really critical takeaway here is that linking female caregivers with support programs where they can communicate about their experiences, that's going to be the most beneficial for them, which is quite a bit different than things that would be helpful for male caregivers, which I'm going to move ahead and talk about since we don't have any comments at this time. Now, for a lot of the reasons that we've been discussing, gender roles, generational conceptions of gender stereotypes and things like this, a lot of caregivers right now tend to be older. And so, Evelyn, what you said about millennial caregivers is very, very true. And millennials are becoming caregivers at quite a high rate right now. So across the board, what has been found for being most helpful in supporting male caregivers is to affirm the role that they're providing, to provide resources, but really to be very strategic. Male caregiver reluctance to really discuss the challenges inherent with the role are very well documented in the literature, and we know that men are less socialized to talk about our concerns and our mental health stress and things like that. So men who perceived that accepting help would really benefit the person for whom they are providing care, that was the best strategy across all of the literature and in practice too. Sometimes there's a disconnect between research and practice, but this strategy has worked very well for me personally with working with other male caregivers. is to make it seem to them that this will benefit the person to whom they are providing care. And that's the best strategy to get them to accept help if you find that they need it. So try to consider that when you're trying to suggest supportive services if a male caregiver seems reluctant to receive help. Very important that we support all of our male caregivers out there.
Okay. Are there any questions or comments?
Well, I have another one.
Sure.
You go for it.
So I was just thinking as you were talking about male reluctance, it seems to me that with COVID, Gen Z may be real different. The men may be willing to talk about their mental health issues because it's become so accepted within our society. What do you think?
I will agree with you. What I'm seeing, however, is that there is more demand for mental health services right now, to a point where I think the quality of services is at risk of being diluted. There are a lot of these online networks that a lot of employers are including as part of employee benefits. This holds true for my university, and I was just looking into all the different options. And the consistency in terms of the quality of services that you would be receiving, it's not the same across the board. That is a concern that I have. And secondarily, what I've heard as well, and I've had this experience, is that if you are calling for mental health services, you don't always get a call back. And to me, that is really a problem. And I'm hearing this from more and more people because people are not accepting new patients. And so they're simply so busy, they're not returning phone calls or directing people elsewhere. And I think that's something we need to all be mindful of as well, that when people are reaching out for help, it takes a lot for them to get there, and we really need to be responsive.
Good point.
Thank you for that. Before we move forward, Elliot, I just want to get your opinion and yours as well, Evelyn. We did a small research to see if healthcare workers are more readily willing and look for services when it comes to men. And what we found is that many times healthcare workers feel, well, you know, a man needs help in the house. They don't know how to do the laundry. They don't know how to cook. And there's that sort of sense that, you know, that they may need more help than women. So I haven't seen a lot of literature around that issue. What are your thoughts about that?
Go
Evelyn,
first, Elliot.
okay. Well, as you both know, I teach health profession students. I teach nurses and PAs and medical sonography students. I teach a wide variety of students all the way through doctoral level. And Evelyn, some of the comments that you've made today hit home for me because I'm seeing the types of changes that you're talking about in the young men that I'm teaching. But what I'm also finding, and I teach students across the country because a lot of my teaching is online, is that it really depends on where it is that you're from and what your cultural background might be. And what Lucy shared about the perception that men need more help as caregivers to manage things around the house, for example, I have a lot of students, female students, who still hold that perception. And I think it has to do with culture and the culture in which you're raised.
For sure.
Well, I'm an old case manager. And why I say old is because, 40 years ago, I was going into senior high rises and people's homes and asking the activities of daily living. And of course, if you're asking a man if they can do all of the tasks that are in the activities of daily living or the instrumental activities of daily living, they'll tell you yes, but it's really their wife that was doing a lot of that stuff for them. And I think that's part of what has changed. You know, men know how to cook. Men know how to iron. It didn't used to be like that.
It's very true.
Yeah, interesting thoughts. All right, since we don't have any questions or comments, so let's go move forward. We're going to talk about LGBT caregivers, but first let's discuss what those letters stand for. And it was a learning experience for me as well. So the current acronym is actually LGBTQIA plus lesbian, gay, bisexual, transgender, queer and or questioning, intersex, asexual and or ally. Now, because it's such a broad acronym, we're going to use the shorter version of LGBT. So informal unpaid caregiving of chronically ill adults is far more common among LGBT individuals than non-LGBT adults. The strongest support systems for LGBT caregivers are needed. We know that, particularly for those who are giving care to a friend and not to a partner or biological family member. LGBT adults become caregivers at a slightly higher rate than non-LGBT peers. So in a recent survey of LGBT baby boomers found that a growing number of LGBT aging adults expect to be treated with respect and dignity at the end of their life. In spite of this, 1 in 5 adults surveyed cited fear of double discrimination, one for being older and one for being LGBT, as a significant concern about aging. Okay, these fears are particularly important to seniors moving into nursing homes or residential care facilities, which will, I'm going to speak a little bit more about that later in the program. But many LGBT people form strong families of choice, in addition to their family of origin, as a way of coping with possibly or actually rejection by parents, siblings, and other relatives for being open about their sexual orientation or gender identity. Even as attitudes have changed in the LGBT people have become more visible and accepted, families of choice still provide invaluable networks of emotional and social support. Nearly 2/3 of LGBT older adults say they consider their friends to be chosen family. Being a member of both a chosen family and a family of origin creates a situation where an LGBT person may become a primary caregiver for a spouse, domestic partner, or legal spouse, a close friend who is also LGBT, or an aging parent or other relative, sometimes at the same time. In the community at large, it is most common for informal caregivers such as a spouse and adult children to provide the majority of care to older adults in the United States. In the LGBT community, with older adults twice as likely to be single and living alone and 3 to 4 times less likely to have children, a family of choice is dependent upon to provide support and care. So LGBT adults are less likely to have children who are a main source of family caregiving. LGBT caregivers are younger, less likely to be married, more racially and ethnically diverse, and more likely to be of lower socioeconomic status than non-LGBT caregivers. Research has already shown that minorities and those of lower socioeconomic status are less likely to access and utilize resources and community support. So it's really important as healthcare providers to be really aware of that and recognize it. So when you are engaging with your clients, to be aware that those things do exist. So the approach to sexual orientation and gender identity and mental health care often groups together anyone in the LGBT community, when these communities are considered at all. This method can be problematic as each sub-community faces unique challenges, rates of mental illness and experience. Obviously, it's like saying everyone that's white is the same. It's not that. We have to be very conscious of that. The LGBT community encompasses a wide range of individuals with separate and overlapping challenges regarding their mental health. Other identifying factors include race, economic status, can affect the quality of care they receive or their ability to access care. Additionally, members of this community may face harassment or a lack of cultural competency from potential providers. These experiences can lead to a fear of disclosing sexual orientation and or gender identity due to potential discrimination or provider bias. So that's a lot to sort of take in. And I'm just wondering if any of you who are with us today have experienced that or have had people feeling a certain way. I'd love to hear from you or any questions that you may have.
There are no silly questions, and we would love your input. So ask away. Press *6 or unmute yourself. Go to the chat room.
And you may have comments also that relate to other diverse communities. As I mentioned, Lucy and I reference this particular community because we do so much work. But this is also true for other diverse communities that have been marginalized, where discrimination has occurred. I say often that a lifetime of inequities leads to inequities in our healthcare, in our health, our wealth, and our well-being.
No, you're making.
Sorry, Lucy. Lucy mentioned earlier when we were talking, I think it was before the call, that she had read an article on people who are hard of hearing and how they're going to be able to access over-the-counter hearing aids for good or for bad. I think there's both sides to that. However, I think, like she talked about discrimination against aging, the discrimination against disability. So many people, especially those with traumatic brain injury or who've had a stroke and have some cognitive function problems, they stand up, they walk, they look like they're okay, but that's an assumption on their part. It's all about asking those questions you talked about, Elliot.
Yes, I think it's really important to be aware of our own value system and our own prejudice, as we all have them, and to be able to step away as healthcare workers and be able to look at people as individuals, regardless of how they look, their color of their skin, their gender. It's not an easy task, but I think that's why we're in this profession, isn't it? To be able to support each and every one and to put our biases aside and just look at the person for who they are.
Well put, Lucy.
Very well put. Well, I'll continue on since this picks up very well on what you just said. And this is something we've talked about in the past too, is trauma-informed care, which is a very important concept in healthcare delivery. But older LGBT adults certainly have unique experiences with healthcare. And if you think about, the mid-1980s, for example, at the height of the HIV/AIDS crisis, the life expectancy for LGBT gay men, as an example, was not very high as compared to today. And so this is really the first older generation of out seniors that many healthcare systems are working with. And we're all learning in the process how to be more inclusive and sensitive. But I think a great part of that, and certainly I think we've touched upon that during the COVID pandemic too, is understanding about where that person's history comes from and what their experience of trauma might be related to their identity. So in the case of the LGBT community, it was not until 1973 that the American Psychiatric Association removed the diagnosis of homosexuality from its Diagnostics and Statistics Manual of Mental Health Disorders. And that's like the Bible of mental health, which is just amazing to me. So if you think about that, let's say someone was born in 1950. They were only 23 years of age when the APA removed this diagnosis as a mental disorder. So all through their formative years, they may have thought that there was something wrong with them. They were 19 when the Stonewall riots occurred, which became the first time that a gay bar in New York was raided and the patrons actually had the courage to fight back. And that was the event that spawned the gay pride movement. Now, that person would have been 65 years old when gay marriage became a federally legal option for that person. So imagine living to be 65 and never being able to get married and to obtain the benefits of marriage like Family Medical Leave Act, which we know is so critical for caregivers who are caring for a spouse. So that person, born in 1950, would be 72 today. Think of what that life experience must be like. And as such, LGBT older adults are 5 times less likely to seek medical care and social services than the general public. So internalized homonegativity is what we call the effect of homophobia turned inward into self-hatred or discomfort with one's own sexuality. And this can be the result of trauma, challenges in intimate relationships. It can also be the result of upbringing and the value system with which we were raised. So this is really part of the why behind an executive order that was issued this past June to advance LGBTQ health equity by President Biden. And many of you, I'm sure, have not heard of this because I have not seen this widely on the news. But this executive order directs the U.S. Department of Health and Human Services to develop and publish a Bill of Rights for LGBTQ+ older adults in long-term care communities. Now, the policy will outline the rights of these seniors to ensure that they're understood and honored. It also enlists HHS to group these individuals with populations of greatest social need under the Older Americans Act. And it also promotes expanded federal collection of data on sexual orientation and gender identity, all measures to make sure that our LGBTQ seniors' needs are being met. Previously, under the direction of the Trump administration, Health and Human Services removed questions about LGBT people from 2 vital surveys, the National Survey of Older Americans Act, which annually measures how older Americans receive social support and nutrition services under the Older Americans Act, and the annual program performance report for Centers for Independent Living, very important report, which assesses whether people of all ages and disabilities are properly receiving services in their homes and communities. Now, removing these LGBTQ measures from these surveys made it much more challenging to know whether these people were being served, what their needs were, and what their experiences were. So this Bill of Rights and this executive order is very, very much needed. We don't yet know how it's all going to play out or what role education should or will have. Now, as a health educator, I'm very big on this because we know that just because there's a change in policy, that doesn't mean that it translates to practice easily. And people will need trainings just like this one to help sensitize them to the needs of patients and caregivers and ways to communicate with them that would signal inclusivity and understanding. Now, we've talked about diversity and culture in many ways so far, but let's take it a little step further. So cultural competence is a big buzzword, and this relates to organizations. It's an old buzzword from 1989, but still used in practice today. And cultural competence is a set of similar behaviors, attitudes, or policies that come together in a system, agency, or among professionals that enable that system, agency, or professionals to work effectively in cross-cultural situations. And that's the actual definition of the term cultural competence. And it includes a valuing of diversity, having the capacity for self-assessment, being conscious of the dynamics inherent when cultures interact, also having an institutionalized cultural knowledge and developed adaptations to service delivery, reflecting an understanding of cultural diversity. So as an example, offering halal and kosher meals if you are a long-term care facility to make sure that you're catering to the needs of all people there. So it's really cultural sensitivity taken to an organizational level. And these elements are very important in delivering care. So I want those listening in or participating to think about when was the last time your organization met to discuss the culture, and were you included? Have there been trainings or discussions about health disparities? For example, many organizations have been recently looking at how to increase COVID-19 boosters among minority communities because of inequities that have existed in our vaccination uptake rates. There are multiple and more recent definitions of cultural competence. It's an entire field of study. You can get a PhD in it, So I think it's important because at the individual level, it really means an examination of our own attitudes and values and how we developed these attitudes and values. And it can be very hard for some people to separate their inherent biases or religious beliefs when providing healthcare. So it's really important, I think, for those of us who are educators, that we remind everyone that you take an oath. It may not be to first do no harm. It may not be the Hippocratic oath, but the oath that we take is really to help others. So connecting cultural competence to that oath of why it is we went into the helping profession is very important.
Could you talk a tiny bit more about cultural self-assessment?
Sure, absolutely. And we're also going to provide some resources where you can take online self-assessments following our program today.
Oh, cool.
So cultural self-assessment is something that can occur within an organization, for example. We have done that at my university, and it led to having more celebrations, for example, where we've done potlucks, where people who are from different cultural backgrounds bring a traditional food and share a little bit about that recipe and what it means within their culture. But it's also, it can be very helpful for organizations to understand who they're serving and help to make sure that their staff is sensitive to the needs of the diversity of that culture. After the Affordable Care Act was implemented, many providers were challenged because their healthcare education did not include training on diversity or sensitivity. And all of a sudden, they had to work with more diverse patient bases. So this became even more important in the clinical practice world and in healthcare systems and facilities of health. So that's why I invite our participants to think and reflect about if your organization has actually put out a survey or an assessment to you or ask you how you feel and if your culture and diversity is accepted and welcome and if you feel comfortable in your place of work.
Great. Thank you.
I remember in one of our sessions, there was a healthcare provider who identified herself and said that in her own organization, she felt that she was being judged primarily by her color and her culture. And that's something that as healthcare workers, if you feel that way in any way, you know that there is a problem in that organization, and probably would filter down to providing services to the people that you are providing services to. So it takes a lot of courage and a lot of guts to stand up first and foremost for yourself. If you feel that you're not being accepted for whatever reason, whatever your culture, language, whatever it is. So I guess the question is, so why does it matter? Should we be, should healthcare workers be sensitive to that? And there's a strong evidence that cultural competency training for healthcare workers improves providers' knowledge, understanding, and skills for treating patients from culturally, logistically, and socioeconomic diverse backgrounds. Additional evidence is needed to determine effects on patient care and health outcomes. That would be very, very interesting. There is reported increased patient satisfaction and improved health outcomes with clinically significant improvements. So we know this is especially true when it comes to long-term care and long-term care planning. And sometimes, unfortunately, placement in long-term care sometimes comes down to availability of a bed and having a means to pay for it, unfortunately. We've been facilitating sessions with LGBT seniors and caregivers on how to find culturally competent long-term care and the importance of finding a facility in which people feel at home. with regard to their cultural or religion is so important. And some of the things could be as simple, which they're not simple, but it's as simple as putting on music that the person is comfortable with, part of their culture. As Elliot said, food is so, so important. Learning and engaging with that person. Language is important. So what are your thoughts on that? What do you think? What are your thoughts on what we're actually saying?
My thoughts are that I'm sensitive to the time, so I'm quickly going to run through the rest of our presentation and open it up, okay? This data here just reinforces everything we've been talking about. Among LGBT seniors, there's a high level of concern in long-term care that a loved one might be neglected, abused, be subject to sexual harassment. So as we've been saying, it matters very much, and it matters to the people to whom we're providing care. There are a lot of, as I was saying, there's a lot of history of healthcare being faith-based, which can be a barrier for many individuals, or it can also be a sense of cultural congruence, rather, where people feel more comfortable, for example, receiving care in an environment in which they feel more connected to. So these are all very important things that we need to just consider as we deliver healthcare. And as I mentioned, we would be providing resources. So this is, to me, the best resource from Georgetown University. They have a Center for Cultural Competence, and I actually include some of their trainings and resources in my own education of our healthcare students at my university. I ask them to take these self-assessments. So your results, if you do take this, remain confidential. You can sign up for free. You can even receive a customized list of professional development resources based upon your self-assessment results. Wow. So these are wonderful, wonderful tools and resources, and we will be sharing them with you as always, in addition to all of these different resources that we have here for you. And before we end, I did want to ask if anyone had any questions or comments.
We've got time for at least one, folks.
I was really good with the time there.
You were really good with that time. Thank you. Right on the dot. Okay, while you're thinking about it, I'm going to tell you we've got a couple of other sessions coming up. Christine Day, can we get a copy of the slides?
Always.
Okay. On Thursday, August 25th, we have high conflict relationships and its impact on you as a caregiver with Dr. Jamie Heisman, very popular presenter. On Friday, the 26th, we have an online call with someone who speaks Spanish. So the whole presentation will be in Spanish. And it's about food being medicine, particularly when you have chronic illness. So that will be a very interesting one. So many folks in the Hispanic community have diabetes. And we know that from the research that's been done, and knowing which foods are going to help you out, and help that chronic illness to get better is going to be really important. And then Tuesday, August 30th, we have dementia and the hidden patient. And that, I think, is probably sort of a cultural session, cultural disability, whatever you want to call it. But it's certainly one of the things that we all need to pay attention to. So for those of you who aren't registered, you need to register in order to be able to get the resources from today. And I'm going to tell you who our customer service person is so that you can call her, our wonderful Minerva, at 866-390-6491. If someone just gave you the phone number for this presentation, you'll need to call her 866-390-6491 and get registered. And you'll be happy you did, because you'll also get the monthly calendar and access to the, help getting to any kind of podcasts that you would like to look at. And it's a very rich resource. They also have the SOS centers in different parts of Texas. Thank you. Now we know that there's the customer service number. Yes, and it's at www.caregiverteleconnection.org. Thank you, Minerva. She's the best. Okay, you guys, any last words?
I just want to thank everybody who felt that this presentation was worthwhile to listen to. Thank you so much and be well.
Thank you. And please don't forget to fill out the post-session survey. That's really helpful for us to know what we can improve upon, what we're doing well, what we can do better. So I want to thank you all again so much for your time, your participation, and for the work that you do.
And whether you're a professional or a family caregiver, thank you.
Bye,
All right.
everybody.
Bye, everyone.
Bye-bye.
Bye. Thank you for the information. I appreciate it. Thank you so much.
Of course.
Very welcome. Bye-bye. Thanks,
Bye.
Evelyn.
Thank you.